This is a case of a 27-year-old female who presents with constant dull, achy pain in the upper right quadrant. She had a root canal on tooth number 4 in July 2013. She states she has spontaneous poking pain in the gum area on the right-hand side. History of present illness. For the onset of this poking pain, this started 4 years ago. She had a pressure in the right quadrant on the upper, so she had an impacted tooth removed. The pain continued with the changes in weather. She had RCT on number 4, and after this root canal, the pain changed to a dull ache with a poking sensation. The location of this pain is the upper right gingiva and bone. The causation is possibly due to the root canal. The quality of the pain is dull, achy, pokey, and itchy on the right side of the cheek skin. This pain is more of a constant pain, the dull ache, and the poking pain is approximately 4 times a day. The constant dull achy pain, again, is more of a continuous pain. The poking lasts about 30 minutes. The pain is mild to moderate. Factors that make it better: cold water. What makes it worse: chewing hard foods and pressure in the area. For the headache history, patient states she has had headaches for the past 5 years. When she was a child, she had a rabbit that would sleep near the right side of her face, and she states she developed some type of herpes reaction on the right side of the scalp, temporal occipital area, which would cause headaches, and she still has a slight numbness in that part of the area. The headaches that she currently has, she believes, are caused by stress. The location is a right frontal area along the eyebrow. It's more of a pressure pain. There's no nausea, photophobia, or phonophobia. These are actually not that frequent, once a month. They last about a day. They're mild to moderate. What makes them better is Advil, and what makes them worse is stress. For the medical history. The medical history is positive for herpes, anxiety and depression, insomnia, GERD, malabsorption syndrome. No known drug allergies. Currently for her medication, she's only taking vitamins and Advil as needed. She does not like to take medication. She's had her wisdom teeth removed and also a surgery for an impacted tooth. Her family history is positive for diabetes and cancer. For the social history, she does admit to clenching her teeth, facial neck tension, and that she is currently stressed out. Her sleep history shows that she has insomnia due to anxiety. For the extraoral exam, when palpating the craniofacial muscles, she did have moderate pain to palpation on right-left masseter, as well as right-left anterior temporalis. Right-left SCM was also moderate, and right-left trapezius was mild. When palpating the TMJ, the left lateral condyle was mild pain, and the left dorsal condyle was moderate pain. She was able to open to 53 millimeters for her max pain-free opening, which is normal, and a right-left lateral max of 10 plus millimeters. No joint noises were detected. For the intraoral exam, she does have mild canine attrition. Tooth number 4 has percussion sensitivity, no palpation sensitivity. Bite stick test was within normal limits, and probings were within normal limits. Neurological test. All cranial nerves were within normal limits except for cranial nerve 5 on the right-hand side V2 area. There was hyposensation to touch and to pinprick. In this case, I did the anesthetic test. I applied endo-ice with a cotton pellet to the gingiva above tooth number 4 for 10 seconds. This produced a lingering pain for about 45 seconds. I then, for reference, applied endo ice to the gingiva above tooth number 12 for 10 seconds, and that produced no pain. I then went on to place 20% benzocaine to the gingiva above tooth number 4, which resulted in 100% reduction in symptoms in 2 minutes. For the radiographs, the pre-op periapical radiograph and cone beam CT from the endodontist showed periapical radiolucency on tooth number 4. The post-op periapical radiograph of tooth number 4, 3 months after the root canal, showed a smaller periapical lesion. This was the radiograph prior to the root canal. Unfortunately, I do not have the post-root canal radiograph, only the endodontic report that indicated the lesion was actually smaller after the root canal was completed. For the assessment, I diagnosed trigeminal nerve disorder, specifically chronic trigeminal neuropathy with peripheral sensitization amicable to topical. I'd also like to rule out cracked tooth syndrome, and I diagnosed myalgia capsulitis and tension type headache as well in this case. For the treatment plan, I gave the patient myofascial protocol with avoidance therapy, end position and stretch, and recommended moist heat for her tender muscles. I recommended ice and Voltaren gel for the TMJ. Patient has GERD and does not want to take any medication. I recommended Oragel to the buccal gingiva above tooth number 4. I also recommended fabrication of neurosensory stent as a carrier for the intraoral topical anesthetic, and the impressions were taken. I recommended a night guard. Patient will decide at next visit if she wants to proceed with the night guard. Possible future crown if cracked tooth syndrome is ruled out. And recommended referral for stress management, as this patient mentioned she is currently very stressed out. For follow-up, we'll deliver the neurosensory stent in 1 week and reevaluate symptoms at that time. We'll reevaluate headaches and possible impressions for night guard. For the medication, I prescribed Voltaren gel 1%, 100 grams, apply to TMJ 3 to 4 times a day. And for the meantime, OTC Oragel topical anesthetic applied to the buccal gingiva of tooth number 4, 4 times a day, until we get the neurosensory stent and she'll be able to place it actually in the stent. So what is chronic trigeminal neuropathy? Well, it's a type of neuropathic pain, and this type of neuropathic pain is initiated or caused by a primary lesion or dysfunction in the nervous system. And neuropathy is described as a continuous pain that does not have a clinically or radiographically evident pathologic basis in the ganglion or CNS. Aching or burning sensation is usually of moderate intensity, and it can be peripheral or centralized. In this patient, we were able to block the pain 100% with topical anesthetic. So this patient has a peripheral neuropathy versus a centralized neuropathy. Well, how do we manage neuropathies? So in a review of the literature, it was discussed that most randomized, double-blind, placebo-controlled trials published in painful neuropathy have been actually in patients with diabetic neuropathy. Tricyclic antidepressants, gabapentin, pregabalin, and SNRIs are first drugs of choice for these patients. In patients with localized neuropathic pain, a topical lidocaine patch may also be considered. Topical treatments are better tolerated due to the lack of systemic side effects. Second-line treatments are tramadol and other opioids. And treatment is usually a trial and error process and is very individualized to each individual patient. There was a systematic review of 5% lidocaine medicated plaster in painful diabetic peripheral neuropathy that was conducted. And the results in this particular systematic review suggest that the effects of pain reduction of 5% lidocaine medicated plaster are actually comparable to those of amitriptyline, capsaicin, gabapentin, and pregabalin.